Hi everyone, it's great to be with you all in the Cardiology Educational channel. I was supposed to be with you live, but due to other commitment, which is of course not important than this commitment, but it necessitated my presence in a physical manner, I elected to record this presentation to you in order to be committed to my role in this great night. Within the next few minutes, I'm going to present, from my humble point of view, the best two AF trials in 2020. The first of these two trials is the multi-center EAST AF Net4 trial, which was presented at the European Society of Cardiology 2020 and published simultaneously in the Great New England Journal of Medicine. This trial randomized patients with AF to early rhythm control or the usual care. This means rate control. The trial was open label but had a blinded outcome assessment. And actually speaking, this trial has an interesting background. As you remember all, the old AFFIRM trial more than 15 years ago addressed this question and found that rhythm control compared to rate control did not reduce outcomes. Much has changed since then, and we have learned the importance of continuing anticoagulation. We have become more skillful in using antiarrhythmic drugs and on risk factor modification, and of course, we now have AF ablation. The simple question that the EAST AFNet trial asked is whether an early rhythm control strategy compared to the usual care would lead to better hard outcomes in patients with atrial fibrillation. EAST AFNet4 was a prospective, open, blinded outcome assessment trial. It included 2,782 patients with early AF and an average CHA2DS2-VASc score of 3.5, who were randomly assigned at 135 sites in 11 European countries to early rhythm control or guideline recommended usual rate control. The mean age of the enrolled patients was 70 years. Nearly half were women and the median CHA2DS2-VASc again was 3. The patients enrolled were actually typical of a cardiology practice. For 38%, this was their first episode of AF, 36% had paroxysmal AF, 26% had persistent AF, and 31% had AF without symptoms. About 90% of both groups continued to receive oral anticoagulation therapy throughout the trial. Patients in the early rhythm control arm received an antiarrhythmic drug or ablation. Actually, adherence was a challenge. Nearly 35% of these patients were no longer receiving any rhythm control therapy. At 2 years, the usual care group was mostly treated with rate control, as I said. The authors chose co-primary efficacy endpoints. The first was a composite of cardiovascular death, stroke, hospital admission for heart failure or acute coronary syndrome, and the second was days spent in the hospital. The primary safety outcome was a composite of death, stroke, or serious adverse events related to rhythm control. Actually, the trial was stopped for efficacy after a median of 5 years follow-up. A primary outcome event occurred in 249 patients in the early rhythm control arm versus 316 patients in the usual care arm. The hazard ratio was 0.79, with a confidence interval ranging from 0.66 to 0.94. The p-value was statistically significant. The absolute risk reduction was 1.1% per 100 person-years of follow-up, and this translated into a 3% absolute risk reduction over 5 years. Each component of this primary outcome was numerically lower in the early rhythm control. In a trial of almost, as I said, 2,800 patients, there was 27 fewer cardiovascular deaths in the early rhythm control. The average days spent in the hospital were similar in both groups. The overall primary safety outcome did not differ significantly between the two treatment arms. However, serious adverse events as shown related to rhythm control therapy occurred in 4.9% of the patients assigned to early rhythm control and 1.4% of the patients assigned to the usual care. EAST-AF-NET trial was a clearly positive trial that had a small effect size and important caveats. But before speaking about limitations and the caveats, let us read the conclusion cited by the authors in the paper. Quote, early rhythm control therapy was associated with a lower risk of cardiovascular outcomes than usual care among patients with early atrial fibrillation and cardiovascular conditions. And now, let's speak about some comments and caveats on this paper. The first caveat is the missing data. This was a 5-year pragmatic trial of two different strategies. Some dropouts, of course, is expected. This totaled 9% in the early rhythm control arm and 6.6% in the usual care arm. One of the experts on clinical trial design said that missing data approaching 10%, I just said, can potentially invalidate an intention to treat analysis. This dropout, as I said, was not uniform between both groups, one group 6.6% and the other group 9%. To be frank, the authors did multiple statistical techniques to accommodate for this dropout, and this upheld the main findings, but we don't know the characteristics of those patients who withdraw their consents or drop out, which is a reason for a pause or a reason for a caution. Another internal validity concern is that the two components, or let's say two components of the primary endpoint, which is hospitalization due to heart failure or acute coronary syndrome, is dependent on the clinician decision. And you know that EAST-AF-NET 4 trial was an open label trial. The investigators knew which arm is the patient assigned to. So consider that participating centers were chosen because they are expert clinicians. Said experts are likely to be proponents for the rhythm control, especially when it involves AF ablation. Unconscious bias may have led to fewer patients in the rhythm control arm being hospitalized. This too is another reason to be cautious. Another important problem is the issue of plausibility, or in other words, why did the results of EAST-AF-4-NET trial differed from those of AFFIRM? The authors highlight the importance of the background therapy, and I agree. Years ago, we falsely believed that maintenance of sinus rhythm allowed patients to stop taking anticoagulant drugs. In this trial, unlike AFFIRM, more than 90% of patients continued taking oral anticoagulants. The trial discussant in the ESC 2020 pointed to the very low event rates in this trial compared to other contemporary clinical trials, such as trials of the new oral anticoagulants compared to warfarin, for example. This was likely due to the strict adherence to the oral anticoagulant therapy and, of course, other background therapy. A take-home message would be that no matter the strategy chosen, if you pay attention to basic preventive measures, patients will experience very low rates of adverse outcomes. Another issue is the effect size. While the 20% relative risk reduction of the events with the early rhythm control in this trial was statistically significant or robust, the absolute risk reduction was modest. As I said, a yearly risk reduction of 1.1% means, in other words, that about 99% of people, similar to those enrolled in this trial, get the same result with either strategy. And remember, this modest absolute risk reduction was mostly driven by non-fatal outcomes. The last problem in this trial is about the net clinical benefit. Although the top-line safety results show no significant difference between both strategies, I urge you to look deeper. The safety endpoint was a three-part composite of stroke, death, and specific serious adverse events or outcomes from the rhythm control. The components here diverged. Stroke and death favored the early rhythm control, but serious adverse events due to rhythm control strongly favored the usual care. Again, they occurred at a rate of 4.9% in patients with early rhythm control and 1.4%, just 1.4% in patients receiving the usual care. The problem comes in using stroke and death in both the efficacy and safety results. When you leverage an advantage in efficacy outcome such as stroke reduction for an advantage in safety, the benefit-risk ratio is usually skewed in favor of the test intervention. The reduction in stroke was a driver for the benefit in the early rhythm control arm. Including stroke at the same time in the safety composite dilutes the effect of serious adverse events due to rhythm control. Without the overlap of efficacy and safety endpoints I just highlighted, the conversation over East AF4 might be that the 3% absolute risk reduction with early rhythm control obtained at 5 years is balanced by a 3.5% higher risk for serious adverse events. My final take before I shift to the next trial is that East AF4 shows that an early rhythm control strategy used in the setting of a clinical trial in highly selected expert centers with good adherence to background therapy, which is not usually the issue in real life, may improve outcomes compared with the strategy of the usual rate control. These potential gains again come with the risk of serious adverse events. Thus, the trial should not be oversimplified to mean please use more antiarrhythmic drugs or please do more ablation. Instead, the nuance and the trade-offs of these findings strongly support a shared understanding between the clinician and the patient. The second trial is called Prague 17 trial. It was published in JACC and it compared percutaneous left atrial appendage occlusion or closure with direct-acting oral anticoagulant in patients with AF. And this trial attempted to fill a crucial knowledge gap. Is left atrial appendage occlusion as good as DOACs for stroke prevention in high-risk AF patients? The background of the trial was straightforward. Of course, given the limitations of vitamin K antagonists for preventing stroke in AF patients, a novel site-specific therapeutic alternative such as mechanical left atrial appendage occlusion entered the clinical practice, but this has not been compared with the current safe and really effective new oral anticoagulants. So, if we consider the rising global burden of atrial fibrillation plus the difficulty of taking a lifelong anticoagulation, a non-pharmacological way of preventing stroke would be a massive advance in patient care. The trial asked a very interesting question. Would left atrial appendage closure be non-inferior to DOACs for clinical outcomes in patients with high-risk AF? The authors in this trial choose a non-inferiority design with a margin of 1.47, which means that the device could be 47% worse than EDUAC and still be considered non-inferior. And actually, this is more rigorous than the Watchman trial. Do you remember the Watchman trial used a 2 and 1.75 as non-inferiority margin? The non-inferiority margin in the old Watchman trial, the Prevail trial, and the Protect AF trial was much more lax than this rigorous non-inferiority margin, and this is good. Investigators at 10 centers in the Czech Republic randomly assigned 415 high-risk patients with AF to either left atrial appendage occlusion or DUWAC and followed them for a median of 21 months. The average age was 72 years, the CHA2DS2-VASc score average was 4.7, this is a high number, and the Hasbled score was 3. About a third of patients had had an embolic event and nearly half had a history of bleeding. Those actually are a very problematic patients. The researchers chose an extremely broad composite endpoint of, count with me, stroke or TIA, systemic embolism, clinically significant bleeding, cardiovascular death, or a significant procedure or device-related complication. Oh, this choice was the key flaw in this trial, as I will discuss later. But all in all, there were 47 primary outcome events in the DUWAC group, where the 38 in the left atrial appendage arm, resulting in a hazard ratio of 0.84 with confidence interval ranging from 0.53 to 1.31. Because the upper bound of 1.31 was less than the non-inferiority margin of 1.47, the authors claimed non-inferiority. Each component of the composite occurred in small numbers, leading to a wide confidence interval, as I will discuss now. The efficacy endpoints, as we see, stroke and transient ischemic attack, were similar in both groups and the hazard ratio was 1. But look to the confidence interval. The confidence interval, however, ranged from 0.40 to 2.5. Components of the composite endpoint were not powered for comparisons, but the upper bound of 2.5 here would have far exceeded the non-inferiority margin I just mentioned of 1.47. The safety endpoint of bleeding was also similar in each group. The hazard ratio was 0.81, had a lower bound of 0.44 and upper bound of 1.52. In other words, the device could reduce bleeding by 56% or, and sit down for this, worsen bleeding by 52%. This is a wash, no advantage. Another safety concern was that 9 patients in the device arm, about 5%, experienced a serious event, including 2 deaths directly related to the procedure. The authors concluded that among patients at high risk for stroke and increased risk of bleeding, left atrial appendage closure was non-inferior to DUWAC in preventing major AF-related cardiovascular, neurological, and bleeding events. And I disagree. We have problems. But please allow me a brief diversion into non-inferiority trial design. One way to make progress in medicine is to develop superior therapies. This is good, but another way to improve patient care is to find therapies of similar efficacy that are more convenient, less invasive, or less toxic than the established treatment. Okay, for instance, in selected patients, a TAVI can be nearly equal to surgery in relieving aortic stenosis, but has the advantage of being less invasive. A DUWAC could be just as good as warfarin for stroke prevention in patients with AF, but have the added benefit of less bleeding risk and more convenience. The putative mechanism of benefit of left atrial appendage occlusion is that mechanical plugging of the left atrial appendage prevents embolic events. Thus, The goal of non-inferiority trial would be to show that the device is not worse than DUAC for stroke prevention, but at the same time has other advantage, such as safety in the form of less bleeding, or convenience in the form of not needing long-term anticoagulation. The DUAC versus warfarin trial serve as a guide. 3 trials tested dabigatran, Relay, rivaroxaban, Rocket AF, apixaban, Aristotle for non-inferiority to warfarin on efficacy, which was narrowly defined in this trial as stroke or systemic embolism. The authors, after that, asked whether the new drugs were superior to safety in the form of bleeding. Of course, you don't need a trial to show that DUACs are more convenient. But unfortunately, that is not what the Prague 17 investigators did. Instead, they included both efficacy and safety outcomes in the same basket. In other words, they muddied the primary endpoint by combining efficacy and safety events in the same outcome. But why this is a problem, let me please explain. Safety is the justification for non-inferiority. In other words, I can say that I am okay if the device is slightly worse as long as it is safer. But putting safety in a composite outcome leads to circular logic, and this biases towards no difference. And repeat this golden sentence after me. If you include events that you expect to trend in opposite directions, such as thrombosis and bleeding, you of course bias to the null and make non-inferiority easier to obtain. But were the investigators obliged to include both safety and efficacy in the same endpoint? The answer is yes. This was of course due to sample size limitation. And indeed, if you look to the supplement in the article, the authors said that they would have needed to enroll 7,000 patients, and I'll say it again, 7,000 patients to have the adequate power to determine non-inferiority on efficacy alone. So, in order to limit or minimize the sample size, they included both safety and efficacy in the same endpoint, and this ultimately biased to the null and made non-inferiority easier to obtain. 2 concluding points before I finish. 1. Prague 17 doesn't change the pessimistic priors we ought to have from the Watchman regulatory trials. To learn whether it is wise to expose patients to a high upfront risk of an invasive procedure, we should await larger trials. The second sad point is that publication of such an inconclusive study will now be cited for years to come as evidence that left atrial appendage occlusion is similar to DUAC, which I think is not the case. This was Ahmed Bindari signing off, and goodbye.